Hello to everyone and welcome to this webinar of the M8 Alliance series on migrant and refugee health entitled How Can Strengthen Healthcare for Migrants Foster Health for All, organized in cooperation with the NGO Emergency. My name is Luciano Saso and I'm a Vice Rector at Sapienza University of Rome and member of the Executive Committee of the M8 Alliance. Migrant and refugee health has been an important topic for the World Health Summit since 2016, and many sessions were organized at the annual event in Berlin, at regional meetings, and at more specific expert meetings. In this difficult and tragic COVID period, we are organizing monthly webinars. More information and the link for free registration is available at the World Health Summit page dedicated to migrant and refugee health. For the meeting today, I would like to thank very much Rossella Miccio, President of Emergency, who will chair the panel, Gina Portella, Coordinator of the Medical Division of Emergency, and Valeria Minardi for the continuous contacts during the organization. I would like to thank all distinguished speakers who accepted our invitation, and Stephen Matlin from the Institute of Global Health Innovation of Imperial College London, who will be the rapporteur of this meeting. For the organization of the webinar, I would like to thank very much Nora Anton and her collaborators at the World Health Summit team in Berlin. I would like now to give the screen to Rossella Miccio, President of Emergency. Always driven by the principle of free and high quality healthcare for all, she has played a pivotal role starting and running the organization's projects around the world. Emergency aims to support some of the most marginalized people in the community, including migrants and refugees. Some of the organization's projects are mobile clinics in Milan, the outpatient clinics in Calabria in Italy, the healthcare assistance on board open arms search and rescue missions in the Mediterranean. She has also worked to develop emergency humanitarian programs in Afghanistan and Sudan. I would like to thank very much all participants for being online today with us and invite all of you to ask questions in the chat in view of the discussion which will be open after all presentations. I wish you a very pleasant and fruitful meeting, and thank you again, Rossella, and please, you have the screen.
Good morning, and good afternoon, and good evening, everybody. It's a pleasure for me to chair this meeting today. Thank you very much to the M8 Alliance and to Luciano particularly for involving Emergency in this very interesting and we hope fruitful discussion today about the link between health of migrants and refugee and strengthening the universal access to healthcare. For Emergency, as Luciana was saying, healthcare is a fundamental human right. Therefore, it has to be granted to every individual, regardless of his or her ethnic group, nationality, religion, and political affiliation, and so on. And this is what we have been trying to do over the past 27 years in our work worldwide. Unfortunately, we have to say that what we are registering, what we are witnessing in many countries, including European countries, and we work in Italy since 2006 with our mobile and permanent clinics, is that in practice there are a lot of barriers that are intentionally or unintentionally put in place, denying the right to healthcare to migrants, and this results not only in a deterioration of the health status for these migrant populations, but also it impoverishes the overall health system, denying really the universality of this health system. So today we will go with our speakers we will have a journey into many countries, European and non-European, because we will also see what the situation is in Australia, for example, and we will have then time to discuss with the speakers and with the participants and to try to draw some lessons out of this discussion. And at the end of the meeting, there will be also a report that will be shared with everybody, and Professor Stephen Matling from the Institute of Global Health Innovation of the Imperial College in London will draft the report. So without further ado, I would like to give the floor to the first speaker, Caroline Berchet from the OECD, whose expertise focuses on health systems performances assessment and on quality and healthcare policies. And she will present the challenges, but also the best practices that within OECD countries to implement a more resilient health systems to face refugee crisis. Caroline, the floor is yours. Thank you.
Thank you very much. So let me share my screen. Okay, can you see my screen? Yeah, so I suppose, yes. So thank you very much for inviting the OECD. I'm Caroline Berchet, economist at the OECD. So I worked on migration issue over the past few years, and today the work that I will present highlight key policies that have been implemented to make health system more resilient to the refugees crisis. So to start with some numbers, it's important to have in mind that immigrant populations have grown virtually everywhere in the past decade. As you can see this graph, between 2000 and 2019, the foreign-born population has increased in most OECD countries, and rather strongly, as you can see in Luxembourg, Iceland, or New Zealand. So overall, across the OECD countries, the foreign-born population accounted for over 10% of its population. Looking now at specific immigrants groups, so migrants who apply to asylum seekers, you can see in this graph that after 2 years of decrease in 2017 and 2018, the number of asylum applications to OECD has increased again in 2019 by around 11%. Of course, the number of new applications is still far from the record high number in 2015 and 2016. And during this period, so during the migration crisis, the high inflows of migrants have been a stress test on integration system in many OECD countries. They had to meet the needs of this population with particular vulnerabilities, a lack of experience in the host country, some language knowledge difficulties, or some health problems. Indeed, refugees and asylum seekers have complex health needs, both physical and psychological. So first, they have experienced difficult travels. They have stayed in transit centers where they might have been exposed to communicable disease, poor sanitation, lack of access to healthy food, or other poor living conditions. And all of these factors tend to adversely affect physical health of refugees. So in some countries, like Turkey, Sweden, but also Australia, refugees experience poor health outcome. And second, refugees and asylum seekers also experience mental stress or severe psychological problems. So linked to the migration journey, but also linked to the past life experiences. So available estimation shows that the rates of depression, anxiety, or poor well-being are at least 3 times higher among refugees than the general population. So mental distress is a big issue among migrants group. So the question is, how can healthcare systems be resilient to better cope and integrate refugees? So based on the OECD framework, resilience recognizes that massive shocks can and will happen, and it's essential that core systems have the capacity for recovery and adaptation. So in the work that I present, we consider key features of resiliency. First, the immediate coping capacity to absorb the shock and meet the need of the population in the short term. Second, the adaptive capacities in the medium term to recover and mitigate losses for the population. And third, the transformative capacity in the long term in order to anticipate future similar crises. So to start with the capacity to absorb, we've seen that some OECD countries have developed short-term solutions to address the needs, the health needs, and provide access to refugees. So for example, OECD countries have organized medical screening program and emergency healthcare provision. It's also important to note that migrants' right to health is guaranteed by countries' national laws and in several international human rights documents. But in practice, healthcare entitlements for asylum seekers vary widely across OECD countries. So for example, full access to care is guaranteed to asylum seekers in only 10 OECD countries, including France, Norway, Netherlands, or the United Kingdom. And access for undocumented migrants is even more restricted and not always granted for free. So this is a big issue. And in general, among the migrants population, we can see that they have a higher tendency to report unmet medical needs than the general population. And the difference is quite high in Sweden, Estonia, Italy, and Greece, where we can see that 1 in 4 immigrants report unmet healthcare needs. Looking now at the capacity to recover and mitigate losses for the population, healthcare systems need to remove barriers that impede access to care. So this entails first providing information about healthcare entitlements, but also removing administrative barriers. So this has been implemented in Greece and Sweden. So to make sure that they know who to contact, to know where to go depending on their health needs, to understand their rights. And in Sweden, in particular, they organized information session for migrants to provide specific information on right, entitlement, but also on health and illness more generally. Second, making access to outreach services is also critical to help them identify their needs, notably mental health needs. So as you may know, outreach services are usually accessible both financially and geographically. And these services are also familiar with the background of the refugees, and they are a trusted source of information. So as shown in Canada and Germany, outreach services have been quite effective in providing information and support, but also referral to mental health services for refugees. Thirdly, obviously, the use of translator is critical to improve health literacy through removing a language barrier. So this strategy is critical to make sure that they receive health information, but in order to participate to decision making, it's also important to increase compliance with medical treatment and increase the trust between health professionals and refugees. So Belgium use new technology during medical consultation to connect doctors and refugees with translators, and this has been a good practice. The last but not the least is to make sure that reception centers are not located in a rural area where there are high shortages of health professionals or health services. And in France, Germany, Ireland, Poland, the remoteness of reception centers has been identified as a factor in hindering access to care for the refugees population. Lastly, over the long term, health systems need to transform service provision and organization in anticipation for future shock. So first, this transformation should be based on greater coordinated action at national level, and it should imply a whole of society approach for greater cooperation between health institutions, non-governmental institutions, private company, international organizations, and so on. Some OECD countries have also established interministerial strategies at national level to address specifically migration issues. So this was a good practice in Greece, where 10 ministries has been involved in a high-level committee dealing with the migration issues. Second, on the long term, education and training of health professionals need to better focus on migrant health needs. So this means including specific training on migrant health in a standard medical and nursing program, but also through continuous professional training. And this is the best way to ensure that health professional and future generation of health professionals can adapt the practice to the needs of migrants and refugees. And so this approach is undertaken in Germany, Sweden, and Spain. Lastly, easing and accelerating the recognition of foreign education for refugee healthcare professionals is critical to integrate them in the longer term. As you may know, many refugees are highly trained, with some qualified as doctors, nurses, or pharmacists. So with appropriate training, appropriate accreditation, and other support, refugee healthcare professionals and migrants healthcare professionals could contribute to address the needs of both the host country's population, but also the refugee population. And so during the migration crisis, innovative policy response have been implemented. In Sweden and Norway, for example, they have implemented fast-track recognition procedure to accelerate the entry of skilled immigrants into the health sector. And in UK and Scotland, bridging programs have been developed to requalify to national standards and secure employment to the refugee population. So to conclude, I would say that many healthcare systems have been resilient during the refugee crisis. We have seen many innovative policy responses. But there are many areas for improvement, notably in the short term, to meet the health need of the population, but also to remove barriers that impede access to care. So I'm talking about the cost of healthcare services. I'm talking about administrative barrier and also problem of communication. To overcome this barrier, we need better integration of migration issue in existing health services and appropriate training of health professionals. And on the longer term, there is a scope to better use the skills and competency on the migrants to integrate them. Countries should not forget that refugees and migrants are an opportunity, so they need to harness the potential, their potential. Thank you very much. Over to you, Rosella.
Thank you very much, Caroline, for this very broad picture that basically tells us that integrating or the response in terms of healthcare system to migrants' needs is not an emergency response, but it has to be a more structural and long-term response that will make our systems more resilient. So this is a very important lesson to learn. And now I will give the floor to Alessandro Lamberty. He's a physician with expertise that ranges from emergency medicine to internal medicine and cardiology, and he has been working with emergency both in overseas project and in Italy, and he will give us a picture of what emergency has learned over the past 14 years actually in Italy, where we have a constitution, within our constitution, the Article 32, that recognizes the right to healthcare as a right of every individual, so not just for Italian citizens, but for all individuals that are passing by Italy and as an interest of the community. But what we have seen in practice is that this right is very often neglected. And one of the main reasons, unfortunately, is that the national health system in Italy is very fragmented. But Alessandro will give us more details about that. So Alessandro, the floor is yours.
Thank you so much. Thank you so much, Rossella. I'm going to share the screen. And thank you so much for your invitation. I'm very glad to be here today representing the International NGO Emergency, and thank you very much again for the invitation. So in order to highlight the barriers the health seekers encounter while trying to access care in Italy, I will be sharing the experience that Emergency has had in delivering care to vulnerable populations. And as you will see, by lowering barriers faced by migrants, it is possible to improve access to care for everyone. So first, let's go through all the topics I will cover in today's talk. First, I will give you a brief overview of Emergency's mission and projects. And second, I will share with you some demographic facts about patients seen in emergency clinics in Italy. Next, I will describe 5 types of barriers experienced by health seekers in Italy: legal, bureaucratic, cultural, linguistic, geographic, and financial barriers. And lastly, I will discuss how insights gained from studying patients seen at emergency clinics can help us improve health for all. Emergency is an international humanitarian organization that was founded in 1994 to provide free, high-quality medical and surgical care to victims of war, landmines, and poverty. And it does that by promoting a culture of peace, solidarity, and respect for human rights. It has worked in 19 countries, building and running tertiary hospitals, surgical centers, rehabilitation centers, and outpatient and mobile clinics. Currently, our organization has a presence in 8 countries and has recently opened, just in 2021, a pediatric hospital in Entebbe, Uganda. In Italy, Emergency has been running a health initiative called Programma Italia since 2011. But despite the fact that Italy has a public health system that theoretically guarantees access to everyone, a variety of barriers prevent individuals from accessing the care they need, creating gaps in care delivery. And Programma Italia has stepped in to fill these gaps, offering primary healthcare, dentistry, psychological services, as well as legal advocacy and support. And today's discussion examines patient data from 2019, and we specifically decided to use these metrics because the pandemic in 2020 was completely disruptive for the whole health sector. So now let's examine the demographic insights that are brought today about the patients seen in our clinic in 2019. As you can see on the left, out of over 11,000 patients seen in 2019, almost 60% are legally residing in Italy, and therefore have a right to be enrolled in the national health system. In many cases, another requirement for the enrollment is stable housing. And we see in the center graph that almost 60% of these patients meet that requirement. You can also see in the third graph that around 20% of patients in 2019 spoke good Italian, and yet they still sought care at our emergency clinics rather than through the national health system. So you see that we have a wide variety of patients encountering diverse and sometimes multiple barriers. And in the following slides, I will break down some of these categories. So now legal barriers. In Italy, only those with a legal residency are allowed to enroll in the national health system. Undocumented migrants are de facto denied enrollment, though they can be provided temporary access. And you can see in the chart that 20% of undocumented patients were able to obtain a temporary enrollment, but still come to emergency for care. And 51% were denied temporary enrollment at an NHS facility and subsequently were billed for services out of pocket. Another 29% at their first contact for medical care with our organization. We provide to these people primary care services and secure temporary enrollment for these patients in case they need advanced care. Now, bureaucratic barriers. Even with a legal residency, people can still face bureaucratic barriers that prevent them from accessing care. By and large, individuals are only allowed to be registered in the national health system if they have stable housing and working contracts, something, of course, that is difficult to obtain when you have a situation of economic precarity. This rule affects three categories of patients seen in our clinic. First, homeless Italians who have completely fallen out of the system. Second, EU migrants without any stable contracts. And third, legal non-EU migrants without stable contracts. And additionally, irregular foreign minors have no possibility of registration in almost all of the regions in Italy. And for these patients, emergency provides clinical services, facilitates temporary access to the national health system when eligible, and provides legal support. And emergency, in fact, recently contributed to a legal case in an anti-discrimination lawsuit against one of Italy's regional governments. And as a result of the court's decision, all irregular minors in the region were given more access to public health services. Cultural linguistic barriers. In addition to legal and bureaucratic barriers, patients also experience cultural linguistic barriers. Very few national health system facilities offer interpretation and mediation services for non-Italian speaking patients. Furthermore, healthcare professionals are not obliged to undergo any intercultural communication training. And as you can see from the chart, 42% of the patients seen in our clinic speak little or no Italian, including many long-term residents. And to help these patients, emergency offers primary healthcare clinical services with interpretation and staff trained in cross-cultural communication. Our organization also provides mediation and interpretation services for patients at NHS facilities. And in 2019 alone, our staff worked for 1,800 hours and drove 35,000 kilometers for these purposes. Geographical barriers, similarly to what happened for cultural linguistic, emergency provides transportation to patients who are geographically distant from health services. Due to a lack of robust public transit and a lack of services for people with disabilities, emergency staff drove 20,000 kilometers and spent 1,400 hours providing transportation to patients attending appointments at national health system facilities. And we also conduct community outreach and offer primary healthcare services via mobile clinic. Lastly, financial barriers. So even when patients experience no legal, no bureaucratic, no cultural linguistic or geographic barriers, they still encounter difficulties when trying to access some services through the national health system. There is very limited coverage for nursing care, for example, or psychological support, or even dentistry. And the limited coverage of these services effectively privatizes these forms of care, requiring patients to pay out of pocket. And this chart shows, for example, the services requested by our Italian patients. And as you can see, 46% of them come asking for nursing services, 20% for psychological support, 12% for primary healthcare and dentistry visits. And they come to us because it would be impossible for them to receive these services otherwise. In conclusion, we believe it is necessary to continue to monitor data from NGOs to understand gaps in care delivery to vulnerable and marginalized populations. And we have the following recommendations for improving health for all: to expand NHS coverage for people of all legal statuses, to render NHS enrollment independent of bureaucratic status, to make interpretation services available at all NHS facilities, to train healthcare professionals in cross-cultural communication, to expand NHS coverage to include all services necessary to maintain health, to make healthcare facilities more geographically accessible, and to harmonize national and regional laws. In one sentence, to be able to measure the success of a health system by the health of the most vulnerable. Thank you.
Thank you, Alessandro, very much for this very detailed analysis and report, where we have learned that the real barrier in accessing the healthcare is actually poverty, marginalization, vulnerability, and therefore is really by taking care of the most vulnerable and marginalized that we foster health for all and we strengthen the health systems. So thank you very much.
Thank you.
And also thank you to all the speakers for keeping the timing so strictly. Thank you so much. We go now to France, where Paul Durnion, research director at IRDES, will focus on the access to healthcare and the social determinants of health. And they will tell us about how immigration-friendly health or non-health policies are or are not present across Europe. So Paul, the floor is yours.
Thank you, Rosella. Let me share my slides with you. Just a sec. Perfect then. Well, thank you very much, Rosella, and thank you, Luciano, for giving me the opportunity to present you what is actually an ongoing work. We are about to submit this work to a journal now with my colleagues Nadi Purat from UCLA University and Lorenzo Rocco from University of Padua. So the title is a little bit long. The general idea is that we wanted to observe whether differences in health and other health outcomes between immigrants and natives would be correlated in the level of friendliness in immigrant policies in European countries. So I think we all know that there's now a large literature on immigrants' health. And what is quite striking is that the results are not exactly convergent. They are very heterogeneous. And what we know for sure now is that immigration, whether it's the country of origin, it's the nature of migration, it's the length of stay in the country or other sub-dimensions of immigration. But immigration in its own is now can be considered in its own as a determinant of social health disparities, at least in developed countries. So that's a very important point. And we also know now that there are large differences between immigration policies between countries, European countries that all have somewhat converged toward socialized health insurance systems. Of course, there are differences between these countries, but all European countries have for long now, especially Western countries, Western Europe countries have now converged toward universal coverage. It's not over, it's not finished, but we all have a socialized health system and still quite different immigration policies. And so we decided we wanted to examine, study the association between these immigration policies and health status, unmet needs, and also healthcare services use, and differences of between these outcomes, between immigrants and natives. It's still work in progress. And let me explain you in a few words how we managed to do that. So we made use of the European Health Interview Survey. It's a large survey, more than 200,000 respondents in European countries, 27 countries. It's been undertaken in 2014, so it's a recent data set. And we have information on healthcare services use, and socioeconomic status, which we know are often considered as social determinants for health. And of course, we also have the information on migration status, and we decided to observe differences between citizens and foreigners. And on the other hand, we made use of the Migrant Integration Policy Index, which is now very much widely used index that enables to measure, provide a kind of metric to measure policies to integrate migrants in various dimensions, such as labor markets, etc., but also health. And so the MIPEX index enabled to measure friendliness in health policies regarding immigration, such as entitlements, accessibility, responsiveness, and policies to promote changes. It's been done in 52 countries, including European countries. You have I added the address of the website so you can check it. And so again, just in a few words, the empirical strategies, we decided we would measure disparities between citizens and foreigners regarding health status, various dimensions of health status, healthcare services utilization, and unmet needs, whether for financial reasons, costs, or non-financial reasons. And in doing so, we wanted to take into account demographic differences, because some of the differences that are observed between migrants and natives could stem from differences in age, class, in gender, and of course also in social determinants of health, being poorer, richer, more educated, less educated. So we took all of these dimensions into account in the analysis, and we observed, that's the second step, if the magnitude and the direction of these disparities, country by country, was correlated with the migrant friendliness in immigration, in immigrants policies that we measured by the MIPEX index that we used as a metric. So we don't have a clear causality there. This is more of a descriptive work, but still we think the results are quite strong now. So let me present you some of the results we have, the most salient results. Better health, but less access to healthcare services. So foreigners report slightly better health than citizens. And that goes along with the general framework of the so-called healthy migrant effect. Again, we are working on foreigners that are usually residing on European country soil for less longer than those who have acquired citizenship. So that was an effect that we were expecting, and that is found in the literature. But the other important thing is that they report lower utilization of primary care, and then they experience more barriers in access to healthcare services, either due to cost or non-financial reasons. And maybe you remember one of the slides of my colleague Caroline Berchet, who also dealt with unmet needs in refugees. So let me tell you again that it's not about exactly refugees, it's about standard mainstream immigrants in the general population. I'm not talking here about refugees, I should have told you that before, but it's really mainstream and main population immigrants, most of them regular immigrants, living sometimes for long in the country of residence. Second step, the link between the health outcomes and the immigrants policy, very interesting results there. More friendly health policies are associated with better immigrants' health, and they're also associated with less non-financial barriers in access to healthcare, to care. That's an important result that we come back to in the next slides. And also more friendly non-health policies are associated with better immigrants' health. And we have mixed results regarding access to healthcare. We have to look more into this. But the interesting point there, again, is that it's not just about the health policies, it's also the non-health policies that matter in immigrants' health. So let me come now to our main conclusions. First, yes, friendlier is better. That might sound simple, but that was not something that we were expecting to, shed light on so easily. This is a very strong result we have. Countries implementing friendlier policies have done better in preventing the health advantage, or at least preventing the health, or doing better for the health outcomes of the immigrants. And so there is a clear information arguing for a clear evidence arguing for the implementation of better and more friendlier policies in EU's countries and elsewhere. That's an important result to us. Again, we don't have causality there, but we still think, because the reverse causality would be very difficult to explain. So there is actually not exactly evidence, but yeah, it strongly, our results strongly suggest this recommendation. I told you I would talk again about that, but access to healthcare services, it's not just about financial costs. Again, we had in the earlier presentation of Caroline Bercher, we also had something about the, I think, Australian and Belgian experience, and then the need for educating and the healthcare professional better. So it's not just, especially in countries who all have implemented some kind of universal coverage of social health insurance, there are still barriers that are not financial barriers, and that's the important thing that the policies have to target now, I think. And so better access is not just about cost, it's also about cultural proximity, language barriers, it's about health literacy, it's about navigating the system, it's about reducing the stigma and potential discriminations. And it's also about working with the health providers in order to produce a better and more inclusiveness in healthcare services. And so another important result of our work is that it's not just about health policies, non-health policies such as access to labor market policies, housing policies do have an impact on immigrants' health. It's important to say it again. So the health in all approach, I think that we all know about, is not just about the general population, it's also about the immigrants' population. And we really have to work better in order to integrate and to include these health issues into all immigrants' policies. And the last thing I want to say is that it's not supported exactly, but it's sort of extent of our results, is that integrating immigration issues in the design of nationwide policymaking is also of importance, is also something that should be important in policymaking. When designing housing or welfare policies, housing policies, access to education, whatever, the question and the issues of immigrants should be raised at the very beginning and in the design of these policies, and of course in their evaluation at the end. So thank you very much. I hope you enjoyed the presentation.
Well, thank you very much, Paul, for this presentation that highlighted a lot of very interesting results and concepts that when we talk about health, we have to take into consideration a lot of interactions with other aspects, particularly when it comes to culture, financial, but also reducing the stigma. In one word, it's inclusion, what we are talking about, and also that the approach to non-health policies can have such an impact also on the health status of migrants and vulnerable populations. So definitely a very important lesson to keep in mind. And when we talk about health, we don't have to think only about the physical health, but one very important aspect that very often is neglected is actually mental health, particularly when it comes to the mental health status of migrants who are coming from a very difficult and stressful situation. Therefore, I'm very glad to give the floor to Mariam Schaller-Ochak. I hope I have pronounced your name more or less correctly, that will focus particularly on the mental health aspect as one of the major needs of the migrants, and how important it is to integrate them into the existing mental health care system to strengthen the mental health care for all. So Mariam, the floor is yours. Thank you.
Thank you very much for this very kind introduction and invitation. I'm very happy to share now my presentation on advanced mental health care, how to overcome barriers and to access mental health care, challenges and opportunities for migrants and refugees. I hope that my presentation can be seen. First of all, I would like to give you a few words on introductory issues when data on immigrants and refugees and asylum seekers in Germany, mental disorders in immigrants and refugees, barriers to access, and then discuss with you cultural competence and ethical principles in dealing with vulnerable groups, and then conclude my short presentation. First of all, I would like to share with you that we have in Germany really a huge population on very diverse immigrants or population with migratory background. 1/4 of the population have migration background, 26% of all population. Looking to their health situation regarding mental health, there are a lot of studies in which there is shown a higher risk for psychiatric disorders, for example, for depression, suicidal issues, psychosis, dementia. Looking to psychosis, for example, it is reported in a lot of publications that overall in the world, the schizophrenia rate is in 1%, but which is this is not true for immigrants because their rate is much higher than 1%. So immigrant population is at higher risk, for example, for psychotic disorders and dementia and so on. Looking to refugees and asylum seekers, first application was seen in Germany till 2014 by nearly 2 million asylum seekers or refugees. So nearly 2 million of them have done first application for asylum. There are a lot of pre-migration problems, life events, but also during the migration processes, they have go through to a lot of traumatizing events. And we know that also after the migration, after receiving in a host country or hosting country, there are also a lot of living problems, so-called post-migration stress factors. For example, uncertainty about future, missing the family, loneliness, lack of daily structures, lack of work, as mentioned before in the talk of Paul, housing problems, lack of privacy, financial problems, and of course, lack of social support, but also social defeat, exclusion, and regarding stigma, racist attacks, and so on. There are a lot of problems to which this population is faced too. And their mental health situation is really, in comparison to the natives, much higher. So, for example, the rate of post-traumatic stress disorders, PTSD, among refugees and asylum seekers are 10 times higher, again, in comparison to the general population. In some other studies, it was reported that the PTSD rates are up to 54% and so on. In average, the spectrum in PTSD worldwide is seen between 13 and 25%, for depression between 8 and 25%. In children, the rate for PTSD is also in a huge range between 4 and 61%. It depends on which kind of life events, traumatizing events these people have to experience. And it is known that so-called human-made disasters have a very, very huge impact on mental health situation of these people. In a study which we did in Berlin, a representative study, we examined 650 refugees 2016, and we could find a lot of complaints, and they fulfilled the criteria, for example, in 33% for PTSD, or in 54% for depression, and so on. And 2 of 3 of them had a psychiatric or fulfilled the criteria for a psychiatric disorder. Looking to treatment possibilities in Germany, we have the law of benefits for asylum seekers. That means that in the first 18 months, these refugees and asylum applicants do not have the full access to mental health care services. So in only acute diseases, pains, or in acute crisis, they are allowed to receive mental health care. After 18 months, they are able to get the full range of treatment possibilities. As mentioned before in other talks, there are a lot of barriers to access mental health care. Of course, language barriers, as mentioned before, new life conditions, circumstances, due to forced inactivity, no structural issues, family left behind, and a lot of barriers about the situation of the family members. Decent housing is needed if the family is in a very small room with maybe 3, 4, 5 people together. Also segregation or migrants job. These are pictograms done by colleagues in a EU-funded project, My Health. For example, in this pictogram, migrants job is mentioned that this is a social defeat. This is a degradation of their competencies and of their capacities. So there are a lot of capacities which are not used, or prejudices, or stigmatizing, and so on. For example, a pictogram on not a terrorist, and so on. So there are possibilities to overcome all these barriers. It's not easy, but I think there is one concept that has been advanced as a way of capturing the capacity to provide appropriate care for these diverse patients or populations, overcoming of social cultural differences and other systemic challenges due to disparities and so on. So this is called cultural competence. That means to know how to work with professionally qualified cultural language mediators, interpreters. Of course, native speakers are welcome, but we do not have enough of them. And another very important part of cultural competency is working with CFI. CFI, cultural formulation interview, is an interview. It is in DSM-5. More than 10 years, colleagues worked on this interview, and it's very important to know which kind of explanatory models do these patients or population have, and which kind of expectations and so on. So to get this information, working with cultural formulation interviews, very important. Intercultural care and so on. So there are a lot of other issues to deal with it and to care with this population in a very good way. And again, underlying that the coverage for cost for interpreters and so on is not clarified in all parts of Germany. In some districts it's possible, in others not. Professor Bugra is the former WPA president, and he said that cultural competence is a multifaceted skill, and it is the heart of clinical, good clinical practice and everybody's or everyone's business. And it's very important to be culturally competent and to understand the patient in the position, circumstances of the patient, and to improve the knowledges and to deal and have a good therapeutic alliance with them and so on. And there are also ethical principles which are very important. Complex relationship between, of course, cultural values and ethics in mental health care. And cultural competence is a practical, concrete demonstration of the ethical principles of respect for persons, beneficent, doing good, non-maleficent, not doing harm, and justice, treating people fairly. These are cornerstones of modern ethical codes for the mental health professionals, for all of us. In conclusion, I would like to underline that access to healthcare services without barriers is a need for all of us, with migration background, with refugee background, asylum seeker background, or general population. So all these barriers should be brought down. Establishing standardized training and qualifications for interpreters and mental health professionals. in cultural competence trainings on individual level, so for example, for me or for my staff, but also in institutional level. That means that the institutions, mental health care or healthcare institutions, should be also culturally competent. That means that they have to work with interpreters, they have to make cultural competence trainings for their staff, they have to prepare information in very different languages, and so on and so on. And to be culturally competent, a clinician must be sensitive, knowledgeable and emphatic about cultural difference, and then make therapeutic use of both capacities. Cultural competence is again a concrete practical expression of bioethics ideals, and mental health providers live out the ethical principles of beneficent, non-maleficent, justice, and respect for persons in their efforts to understand, appreciate, to emphasize with their patients' cultural values, and to use those abilities in the service of excellent patient care. In these circumstances, we do not talk about COVID-19 pandemic. This is, in my opinion, a burning glass regarding these vulnerable, very heterogeneous groups. They are really very difficult to reach, to be reached through preventive concepts and so on. So we have to think about also this part of the care, mental health care. I would like to share with you also the EU Charter for Fundamental Rights, where is outlined that the notion of a universal right to access healthcare, stating everyone has the right to access to preventive healthcare and the right to benefit from medical treatment under the conditions established by national laws and practices. A high level of human health protection shall be ensured in the definition and implementation of all union policies and activities. And my last slide, according to WHO 1948, health is a fundamental human right recognized in the Universal Declaration of Human Rights. Thank you very much for your attention.
Thank you very much, Mariam, for this very, very interesting presentation that highlights also, I think this is something very important, how the work of cultural mediators is important, not just as translators, but really someone who can be a bridge between different cultures, different works, and this has to be embedded in our health policies, also the development of professional skills of our health specialists, particularly when it comes to mental health. Very, very interesting. And then we will leave Europe now and go on the other hemisphere, to the opposite hemisphere, to Australia, where Donata Sake, Director of Mother Refugee Health Services, will bring us to Brisbane, Australia, and will tell us about the different status or the difference in access to health services for refugees that are registered under the Australian humanitarian program and asylum seekers that are still left behind in the system, if I'm not wrong. So Donata, the floor is yours. Thank you.
Thank you, Rossella. I'll just share my screen with you. Thank you for the introduction. Thank you, Luciano, for allowing Australia to be part of this wonderful panel. And I feel that there's quite a lot of synergies with what the previous speakers have spoken about in terms of the clinical and the policy work. So today I am going to take you to Australia in Brisbane. But first, if I may, I'd just like to begin by acknowledging the traditional owners and the custodians of the land which we meet on today here in Brisbane, the Yagara and the Turrbal people. And I'd like to pay my respects to their elders past, present and emerging, for they hold the memories, the traditions and the culture and hopes of Australia's First Nations people. And I just want to pay note and respect to the fact that there are more than 250 Indigenous languages, including 800 dialects and 500 different clans that live in Australia alongside all the other migrants. And again, just by way of context, Queensland, which is the state that I live in, is huge, and you can see that the state of Queensland probably contains easily France, Germany, Austria, Switzerland, England, and Scotland. So we are a massive geographical region, which proves to be quite a challenge in delivering services. Again, just to give you a bit of context, that is Brisbane City where I live. Minjin in the Turrbal language is Brisbane, and that's the Brisbane River. And that is the Mater Hospital, where I'm currently in a very dark room here in the Mater Hospital, a few kilometres from the CBD. So again, by way of context, Australia is a land of migrants. Just over 25 million people, so it's a relatively small population, but a huge continent. And 30% of the people living in Australia are born overseas. I think that we probably represent almost every country in the world. 47% of Australians, or a little bit above that, have one or both, are either children of migrants or were born overseas. And in one way or another, apart from the Aboriginal people who make up just about around 3.3% of the population, all of us are migrants. I came to Australia when I was 10 years old from Italy, from Roma. Again, Australia does have a universal healthcare insurance system, and the two pillars of that are Medicare and the pharmaceutical benefit scheme. But aside from having access to emergency care for the majority of Australians, and we've got access to a hospital and primary care, 9 in 10 Australians have visited a GP on average. And we also have the opportunity for a private health insurance. We actually also have some growing gaps between those who can afford private insurance, those who can afford the access to a hospital system without waiting lists. We also have the geographical challenges of servicing a big remote area. And we also have two levels of government, the federal and the state government, which become very complicated in the whole way of administering healthcare. So our refugee program, which is under the Humanitarian Settlement Program, is probably one of the sort of renowned or generous programs. We probably are the third largest resettler, and we're a very well-resourced humanitarian program by comparison. We, however, settle a drop in the ocean. So in 2018-19, just before COVID, we permanently resettled 16,363 individuals. The government has announced that they're actually going to drop the intake after we open our international borders. And you can see the country of origin usually reflects the conflict that's going on in the world. Asylum seekers, however, it's a very different approach. And I just want to, I'm not going to go through a whole history of where our asylum seeker program is, but I just want to draw your attention to two things that have happened. So in 1999, we reintroduced a temporary visa protection program, which then led to a whole other number of changes in our policy, and our policy context from about 2013 became one of turning back the boats under the Operation Sovereign Borders. And at that point in time, Australia made a decision that if you came here without a visa and you came here by boat, you will never be allowed to take on a permanent residency. So on the and one of the other things that I guess is probably known worldwide is that in order to be able to deter people who come here without a visa, we basically detain people, and we can detain people anywhere from on average 450 days to up to 9 years, which is unconscionable and totally inhumane. As on the 28th of February 2021, there were approximately 1,500 people locked up in detention facilities onshore and offshore. So that is why I call this short presentation A Tale of Two Migrants. We have refugees under the humanitarian program. That policy's intent is to welcome and settle people into Australia and make them feel like part of the fabric. And a lot of the friendly policies that we've spoken about, including non-health policies, have been directed at the humanitarian program. And then on the other hand, we have asylum seekers where the pure intent of that policy is to deter and to punish people who come to Australia purely to seek asylum. And I've done a comparison table as to what access to what social supports and health supports people have. And the only two things that are comparable is access to interpreters. And I have to say that after hearing a lot of the previous speakers speak about the importance of interpreters and translations, Australia has had for a very long time a free national translating and interpreting service, which all GPs in primary care can have free access to, so can pharmacists, and so can a whole host of other people. So interpreting is regarded as a cornerstone of what we do in Australia as far as delivering health and other services. There is also an opportunity for torture and trauma services to provide care to asylum seekers. So Australia has a very comprehensive program called the, it's a forum of Australian services for survivors of torture and trauma. And there's a service in each state and territory that we as health providers work very closely with. However, COVID created a whole new dimension in Australia. Australia has not been affected by COVID anywhere near to the shape of other countries. However, we've taken on a very fortress-like mentality, and our borders will be shut until probably 2020, which means that a lot of people will not be able to access Australia, and we've dropped our humanitarian program almost to zero. We have about 20 people we've resettled in the last 6 months. I'm not going to labour over this, but I'm now really moving into our service. So we deliver both a clinical service, so we have nurses and doctors, and we also have a network which focuses on the policy and integration of the two. So all these challenges, every other speaker that's spoken before me has alluded to these challenges. And the issue of trust and low health literacy are very critical to the way we shape our service. So in building our response to how we would like to deliver care, these are our fundamental principles that we look to. So the right care, the right place, and the right time. So what does that look like? It looks like access, quality, and coordination. And when we talk about access, we talk about looking at those barriers such as language, so providing interpreters, geography, where people are living, how far people are living from their health service, how friendly there's reception and engagement, how comfortable people feel when they arrive into a clinic. Quality, so the building the capacity of the clinical leadership. We just heard the previous speaker speak a lot about cultural competency, and for us, cultural competency is embedded in how we deliver care and how we access interpreters and how we would like our clinicians to be trained right from the beginning all the way through to specialist care delivery. And coordination is reflective of the integration of primary care healthcare models. So we understand that health doesn't happen in isolation, and so we must integrate the care across a number of different systems. In Australia in particular, because we have a split primary system that's delivered and funded by the federal, and we have a hospital system delivered by the state, we also have that level of fragmentation. So all of this is underpinned by our Medicare model. It's also underpinned by our National Translating and Interpreting Service and our Specialist Refugee Health Funding. So each state and territory in Australia receives some specialist funding, like our service does, to deliver refugee healthcare. It's also about community engagement. So most of our programs, in fact, everything we deliver here at the MARTA has got a consumer partnership approach. So all of our community engagement work is done with a very strong lens of having our advisors involved in our direction, and then also the policy work. So the integrated primary care model, which is really the cornerstone of what I've been talking about, is that we've essentially co-located our refugee health nurses, who are hospital-based nurses, into community general practices. We've identified practices where, in partnership with our settlement service, we've identified where people live, and we've co-located our nurses in those GP-friendly practices. And it has had the benefit of increasing the clinical and admin and practice nurse skills. So, for example, the engagement of interpreters went up, the knowledge about interpreters went up, their cultural competency and confidence in dealing with the patient population went up. We also saw an increase in number of health assessments being delivered, the number of referrals to our TB service, oral health services, and also for us, another indicator of a quality outcome was actually completing the immunisation schedule, catch-up immunisation. We also saw an increase in dealing with social determinants. We saw a reduction in the duplication and fragmentation of care. And embedded in our model with our nurses is that there's an opportunity for health literacy with an interpreter at every encounter in the general practice. And if people are interested, that's the link to an article that we published just on trying to, I guess, articulate this model. And there is some pictures of our practices and some of our refugee health advisory group. And lastly, most importantly as well, is that the asylum seekers, because even though they can access some of the care if they have Medicare, they are actually excluded from that policy discourse. So part of the Refugee Health Network Queensland, which is auspiced by us at the MATA, is to actually advocate for changes in policy. And that document is a document that we co-wrote with our Department of Health, which articulates some of these principles and some of the actions that we would like to see. We also deliver a specialist complex care clinic to people who have nothing. Bit similar but different to the emergency clinic in that we have specialist primary care clinics with GPs who do pro bono work. They provide also funding. We provide funding for investigations and medicine. And so this is for the cohort of people who have no Medicare and access to no other services. So in conclusion, I guess I'd just like to make the point that health equity is definitely better for all. And from our point of view, if we design services with community in mind and partnering with community, COVID has shown us that it is only when there's trust and there's capacity to engage and co-design messages and co-design services that we actually develop a better uptake of services and better outcomes and a more authentic partnership. And just the very last point, the other outcome that's happened for us in terms of diversification of the workforce is that we've also been able to focus our policy efforts on pathways. So at the moment at the MATA Hospital, we've just had our third observer, an international medical graduate who've gone on to, from refugee background, who've gone on to full employment in our health system. And the observership was a pathway to help. But I don't have time to talk about that, but I recognise that one of the speakers spoke, the first speaker spoke quite a lot about how do we engage the skill set of our migrants and refugee populations. And that is clearly something that's on our agenda. And I guess last but not least, economic efficiency. We've seen an improvement in the uptake of services. And if people are interested, these are some of our resources and some of the guidelines for working with interpreters and working in a culturally sensitive manner. So thank you very much, and I'll stop sharing. And I'm sorry if I have gone over time.
Thank you. No, thank you, Donata. You were absolutely on time. So we actually have about 45 minutes left for questions. And I would like to thank all the speakers for their presentations and for giving us so many different inputs. And I invite all the participants that would like to ask questions to the speakers to write the questions in the chat. I know that there is Jeremy Pine who would like to ask a question. So please, Jeremy, if you can write it down in the chat, I will deliver it to the speakers. Meanwhile, I would start having my question, if you allow me, because we have heard a lot of different very interesting inputs, and I was wondering how, and this is for all the panelists, how do we think we can really maximize all these inputs and avoid to have, let's say, like having a focus on health of migrants that will turn just into a parallel health systems for migrants that will just increase, let's say, the separation between the migrant community and the local community, rather than work towards an inclusion, a real inclusive system that will at the end benefit the entire system. Because sometimes this is what we see, at least in Italy, where very often migrants' health is left to NGOs, civil society organization, charity organization, and it's not fully, let's say, embedded into the national health system. So we see it as a risk, because it's a further segregation rather than an integration. So this is open to all the speakers, if you want. Who wants to?
Yes, Mariam, please, yes.
Thank you. Maybe I can start. In Germany, we have till mid of 50s, last century, received a lot of work migrants and their families and so on. So there was no integration into the existing healthcare system. And there were, from the beginning, always special services for, I think, for people from Turkey, people from Greece, I don't know from which part of the world. So they were not included in the existing system. And this is an experience it's going on also now in the population of refugees, asylum seekers, and newcoming immigrants, and so on. But there are also parallel services in which these new immigrants, refugees, asylum seekers also integrated. So there are possibilities, and there are really good clinical practices if we discuss them much more in the public system, health system, and so on. Also discuss them with insurance companies and so on, politicians. It could be possible to integrate them into the whole system. There are also other centers, for example, Center for Treatment and Counseling of Torture Victims, and so on. Of course, these centers should exist going on and work in parallel, but this should be for a limited time. These special offers or services should be, in my opinion, a bridge to integrating them in the existing health system and not a parallel system. We experienced in the last decades a lot of about parallel systems, and it's I think much expensive looking to the cost than integrating them. But for integration and participation in these systems, it is very important what one of the speakers mentioned before. I think it was Paul, I do not remember it very well. It's very important to reduce discriminative issues, racistic issues, prejudices, and so on. And therefore, in my opinion, it is very, very important to include, I'm talking again on a cultural competence, to make these colleagues, all of them, not only the psychiatric system, but GPs, I understand in Australia there is a very good concept. So to include these competencies to all disciplines and in all services could be, or to implement it, could be a possible way to reach one day an inclusive system. And I think this should be the goal, our aim, where we would be like, see us maybe in 10 years, or I don't know how long it would take, but the will of politicians and insurance companies are very important in this issues. Thank you.
Thank you, Mariam. Is there any other?
Yes, Rossella, there are people raising hands, Caroline, and then Donata, and then Paul.
I don't see the hand, so.
Yeah. Yes, thanks. I think another important point to have more inclusive policies is to work better across the different sectors to deal with migrant health. So it has been raised by Paul, but also other speakers, and I think this will be important in the future. So it will require change in governance, but also change in financing model, change in training. And I think that the example from Greece during the migration crisis, where they set a high-level committee for the coordination of immigration policy and social inclusion, was a good example because it included like 10 ministries, not only focusing on health, but it has enabled to include migrant health issue into the other sectors. And I think this is a good practice. Over.
Thank you very much, Caroline. I see that also Paul has a hands up, and also Donata then.
Just a few words on the French system and experience. We do have implemented a health insurance program for undocumented migrants. We have it covers as of today, it covers 300,000 undocumented immigrants in France, and it provides them basically the same basket, like primary care, secondary care, drugs, etc., that has the general population free of charge. And what is striking is that it's not a threat to the system. I mean, it's important to say it, like it won't kill the system. It's not too expensive for us. It represents less than 1% of total health expenditure of the French healthcare system. And the real important thing is that what we observe is a large non-take-up of those who should be allowed to access the system. 50% of undocumented immigrants do not access the insurance system. So it's not just about all the immigrants, rushing to Europe to get access to the welfare system. It's not that. Actually, it's rather the opposite. And it's as of today, it's not a financial threat to the system.
Thank you, Paul, very much. Donata, the floor is yours.
Thank you. I mean, I totally agree with what everyone said, that embedding and integrating refugee health, migrant health into whatever is going on mainstream is really important. You do, however, still need to maintain some specialist type services, whether, torture and trauma was mentioned just before. But I think the most important service that makes our system work is the TIS, is the Translating and Interpreting Service. I think without that nationally funded and available service to every single health provider, you're actually going to limit your scope of access for anyone to start with. So I would really want to kind of promote an awareness of language and interpreting as the fundamental first step.
Thank you. And then I see also Alessandro. So please.
Yeah, I just want to add a couple of points. I really enjoyed Donata's presentation because she was putting a lot of stress on the primary healthcare system, which is usually the first point of care with vulnerable populations. And for example, the experience I have in Italy is the primary healthcare system is very weak, and through its weakness, it is not possible for the system to identify where the vulnerable populations are. And this is, I guess, the important role of NGOs, especially in so-called first world countries like Italy. People would be like, why do you need an NGO in Italy where the public health system is so strong? Well, you need NGOs, especially for that. especially to help see the people that are not integrated within the national health system. So, of course, let's talk about migrants and refugees, but also let's talk about vulnerable populations. And the role, I guess, the organization that I'm very proud to be part of is doing is by building research evidence on this, by looking at where the vulnerable populations are and what their health needs are, and also the integration that the NGO system, the emergency NGO system, does with the public health system. So we don't want to be a surrogate of the health system, but we want to cooperate in identifying where these vulnerable populations are. And we, for example, do even support and training and education to public health workers, because we have the experience in identifying the needs of this vulnerable population. So I guess cooperation is the answer between all this, among all these different people, you know. Thank you.
Thank you, Alessandro. I see Caroline with hands up. Okay.
Yes, thanks. I just want to echo what Alessandro just said. At the OECD, we just published a report on primary healthcare across OECD countries. And we've shown that primary healthcare is associated with lower health inequalities. So for sure, primary healthcare is critical. It ensures access to vulnerable populations that otherwise can struggle to access to medical care. And this should be strengthened across OECD countries without any doubt. Thanks.
Thank you very much, Caroline. And now I have a question from
Mariam.
Oh, yeah. Sorry, Mariam.
I would like to underline that the importance of primary healthcare is really to be underlined and pointed out. And in that situation, the staff in primary health care should be really qualified in regarding screening issues, find out who is really, for example, traumatized and so on. So because otherwise it's possible that the chronification of mental disorders are going on, and the treatment possibilities are much more difficult in future. So it would be great to have interdisciplinary and transdisciplinary cooperation issues or tracks working along these tracks to find difficult population, for example, undocumented ones or pregnant ones, or I don't know, traumatized ones, and so on. So working together in different sections would be great if we can realize it.
Thank you, Mariam. This is exactly what we do. For example, in emergency, in our clinics, we have a multidisciplinary team. So from nurses, cultural mediators, primary healthcare doctors, psychologists, and so on to deal with the patient. So yeah, definitely this is a model that we can support and advocate for as a general model. Very good. So if there is no more hand up, I will move to the question from Jeremy Pine, who is an independent scholar from the US. And the question is for Caroline, for OECD, and for emergency representatives. And he says, in the USA, where I'm from, we see a vastly unequal health system that was exacerbated by COVID-19. In response, community activists and mutual aid programs have stepped in to try to meet the needs of vulnerable groups. What types of collaboration, partnerships can you envision happening between civil society organizations and these mutual aid groups that are composed of oppressed, vulnerable individuals? Might this be something that could be a powerful advocacy tool? So Caroline and Alessandro, the question is for you, but I think that also other speakers can
yes, thank you very much for this good question. So yes, I think could be a powerful advocacy tool, and we can see some innovative practice across OECD countries, where in some countries where undocumented migrants or other migrant groups face difficulties to access to free healthcare, local authorities have adopted some more favorable health policy toward undocumented migrants. So in Sweden, for example, this is the case. In the city of Stockholm, they has encouraged health providers to give undocumented migrants access to free healthcare. This is also the case in Belgium, in Canada, and in the US. As you may know, like San Francisco, Los Angeles, or New York City, they have such initiative, and I think it could be a powerful advocacy tool. Yes. Thanks.
Thank you, Caroline and Alessandro. Do you want to add anything?
I just want to reiterate what I've just said. As a representative of emergency, we believe that the cooperation with civil institutions, with the private sector, with other NGOs, and of course with the public health system is the way to go. And perhaps Rosella, you want to add something as the president of the emergency, but I guess this is the most powerful advocacy tool, the multidisciplinary interaction and trying to solve the problems through a multidisciplinary approach.
Yeah, if I can add to this, we have seen, particularly last year during the COVID pandemic, how important was the collaboration between NGOs who had, for example, like Emergency or Doctors Without Borders, a previous experience in outbreak management to support the national health system that, particularly in Italy, was quite shocked by the outbreak, and this allowed us to to early identify the signals for the consequences of the outbreak, particularly on the vulnerable groups. And we developed programs with local authorities, so local municipalities, but also with the regional and national authorities, particularly to deal with infection prevention and control, protection measures, information programs for all those who were left behind, homeless people, unaccompanied minors, reception centers for refugees and migrants who had not, who could not respect the standards for isolation and so on. But also we worked within the within public hospitals in Italy dealing with COVID, and this allowed really to have this interaction. And this experience, we think, can be definitely a model for advocacy, but also for an evidence-based development of best practices that can be replicated and shared. So I think that we should really build on the experience of this pandemic that was a big crisis, but was also a big opportunity, perhaps, in order to work on the enhancement of inclusive health system. So definitely, yes. And then Donata is also willing to give an answer, and then Miriam.
I just wanted to add that a really powerful advocacy tool that we've kind of really nurtured is the partnership with our community. So since 2016, 2015, we've had a refugee health advisory group, which we refer to as the G11. It's a group of 11, and they kind of started as a G4, a G3, G6. But essentially the model is that we've work alongside a group of individuals from different refugee backgrounds who we regard as consultants to us. So they've all got other jobs, but they are consultants to us, and they act like a bridge between their communities and the health system. And so whenever we're looking to, for example, write the policy and action plan that I showed on my slide, they were involved in some of that work. They're also the ear to the ground for us to help us understand what the communities are saying, what they're missing. So if, for example, there is a mental health often comes up as an issue, but how do you provide information to communities? So they actually are the conduit to those communities. They're a trusted source. And then we provide the clinicians that might provide the education and the information. So what we found during COVID is that governments were really struggling to cut through with their messaging, and for whatever reasons, even if they were translating information, the level of trust in Australia around what the government was saying was low. And so what we found was that because we had these long established partnerships with communities, and we've actually built infrastructure around that, we've provided training and support and payment and funding, we were able to very quickly pivot that group to then provide not just translations, but they did audios that were shared on WhatsApp, on Facebook. They were able to connect with their communities through their social media networks. And we were able to reach more people than what the funded government services were able to reach, because they were using websites and they were using their standard media. So I guess in answering that question, I think it might be very powerful to have very strong community development approaches, which are more akin to less developed countries, because community development is often rooted in kind of community participatory action. But I think it works extremely well if you invest in a real strong community development model. And we have written about the G11 model, but for us, the G11 model is just the beginning of the ongoing partnership that we have with them.
Thank you, Mariam.
Thank you very much. I would underline or give the information that also in Germany it is possible to be treated by undocumented immigrants or people without any documents and so on by some NGOs, but also some governmental services. So it's also possible in Germany, maybe not German-wide, but in some parts of Germany, it's very good possible. And they do not need to give any personalized data. They can get these services or treatment possibilities in an anonymous form. Another issue which I would like to underline is advocacy by migrant organizations, but also communities. For example, in Berlin, we have a community of Turkish people with Turkish background or with Greece background, Arabic background, and so on. But we have also German-wide, not only in Germany, in other parts of Europe and so on. There are a lot of very active migrant organizations who could be advocative organizations for these sometimes very difficult to reach populations, and working together with them could be very helpful. We have experienced it in the past, and include them to, for example, information campaigns or awareness issues and so on. Another issue is for example, social media, as mentioned by Donata, or other media like TV and so on. Sometimes it could be very helpful to have these information in their languages without translating and so on, to have maybe one session in the week about COVID-19 pandemic and its impact on health issues and so on, maybe in Turkish, maybe in Arabic, maybe in, I don't know what else language is needed to reach these people too. Otherwise, it's not possible. Written information do not reach them. So it's difficult, because I know that Arabic population or people with Turkish background are listening to TV from Turkey, from I don't know where else. And the information which they receive from these TVs are not the same as in their surrounding, in their social contexts in Berlin or where else in Germany. So this is, I think, also a possibility to share very important information to these difficult to reach population via TV in their languages.
Thank you very much. So if there are no other speakers that would like to answer, we can go ahead. There is a question from Rocco Parisi from a local health authority in Ragusa, Sicily, southern Italy. who's asking when is possible to ensure a full integration, particularly for young migrants, and if integration in the health sectors implies also different integration policy, like the job placement and so on. So I think that perhaps this can be a question also for Paul, and who else wants to answer?
You're right. I can maybe say a few words. It's a very good question and a suggestion. I think yes, that's the basic idea of health in all policies. I mean, combining a health approach or investment in health and in investment in the access to labor market, say, is probably very important and would produce higher outcomes in terms of whatever health status and access to healthcare services. That's for sure. That's the exact. I think that's the lesson we have to learn. That actually I learned from my recent research.
Thank you, Paul, and Caroline as well.
Mm-hmm. Yes, thank you. Yes, I totally agree. As I said before, refugees and migrants are highly trained and really qualified people, so particularly in the health sector. And already today in the health sector, migrants account for nearly 25% of medical doctors and 16% of nurses. So us country need to integrate them in labor market. It's a win-win strategy, both for us country, but also for the population in itself. So they need to harness the potential of highly qualified migrants and refugee population. Thanks.
Thank you very much. Any other comment from the speakers? Miriam?
Yes,
please?
thank you. I would like to underline that it's important to have concepts like job coaching or other issues. So if you have young refugees or asylum-seeking people via the help of job coaching programs, it could be possible to bring them into a job and to implement these systems, not only partly in one town, so over many districts. It could be very helpful to integrate them.
Thanks a lot. And now Donata.
There's been a recent piece of research that was done here in Queensland in particular, that by Deloitte Economics, where they looked at the migrant and refugee population's contribution to workforce. I can give you the link later on, but one of the things that was, apart from what everyone has said, the underutilization of the skill set of that population, the biggest issue was around networks and local experience. So there was a real sense that the expectation that you would just get another certificate, or you just learn a bit more language, you just do a little bit more, then you'd get work, was actually not accurate. What actually got people employment was the opportunity to build networks and build relationships and be in the workplace where they could actually connect, they could learn from other colleagues in the workspace. So we have taken that on board very kind of literally almost, because we've been pushing for internship positions in the hospitals, like the assistant in nursing internship program that we're running for refugee background nurses, and also an observership for international medical graduates from refugee background, because I think the bottom line is that the system is very resistant to allowing people to just come in from other countries. They look with skepticism on people's qualifications and people's experience from overseas. I don't know about the rest of Europe. It's been a long time since I've been in Italy to live, so I don't know. But in Australia, the sort of the inherent bias in the system is to discriminate against people who speak different, who look different. And so I think the Deloitte report really highlighted the importance of building networks, professional networks, and giving people the opportunity to have some work experience and engagement.
Thank you, Donata. Yeah, definitely this is something absolutely important, also to build the trust among the different communities. And I mean, in Italy, and particularly in the region of Ragusa, where Rocco is from, we see this a lot of work exploitation, actually, because most of the agricultural sector in that area is run by migrants that whose rights are absolutely not implemented, and this of course has an impact a lot on their health status and also on their let's say a condition of marginalization from the rest of the community. We have seen people in that area that have been working there for ages and still they have no contact at all with the local community, and this is really starting a spiral, a vicious circles that that really deteriorates not only their conditions but the situation, the health context at all. So definitely this is something very, very important. So thank you very much, and thank you, Rocco, for this question. Sorry, I got muted. Then there is a comment from Sonia Novak from the Center for Health and Migration in Vienna. And she says, sorry, I'm getting many thanks for all your interesting inputs. And at Paul, I completely agree with your statement that the costs are not too high. Our research at the Center for Health and Migration shows that providing access to healthcare for irregular migrants is even cost saving. And I think that perhaps we can, Paul, if you want, focus a bit more on this economical aspect, because this is something that has an impact, particularly because financial resources are limited everywhere. So also to have this different point of view, or a viewpoint, actually, rather than point of view from the economic point of view, the potential positive impact on the resources needed to guarantee an equitable health system to migrants can be important.
Yes, the question of avoidable cost is always a tricky one, especially when it comes to health expenditure. It's very difficult to prove, to assess that more expenditure today, more healthcare consumption will lead to less expenditure tomorrow. It's very difficult to provide evidence on this. Still, I mean, the evidence we have is that better access to coverage means also less use of emergency room and that kind of hospital care. And this is very, I mean, in terms of hospital organization, we all know that it's much better, I mean, for the hospital to not to have like too many people in line in the emergency room. At the same time, there are many conditions that cannot be addressed well only through the emergency rooms. Like if you decompensate from your diabetes or whatever, you cannot just, I mean, go to the emergency room every 2 months. This is inhuman. This is not efficient. This is very costly, although it's difficult to prove, but it's obviously costly. On the long term, it's for sure better also in terms of financial aspects. And also, of course, access to primary care means more prevention. That's another important thing. The last thing I want to add, by the way, it's linked to that, of course, is that, I mean, another thing that has a strong effect on immigrants' health and the health expenditure is their situation in the country of the receiving country, the host country. Living conditions in France and in other countries, in Europe at least, are often dire, like dire. I mean, if you visit Paris, the northern part of Paris today, it's I mean, it's a shame, it's a nightmare. And these have clear impacts on PTSD, this is something we're working on today. And so on mental health, and of course tomorrow on health expenditures, because these people, they won't just come back to their home country to be treated, to their origin, country of origin, birth country to be treated. They will stay here. They will stay here, and the less well we treat them now, in terms of living conditions, the more problems they will have, and the more costly it will be tomorrow. We can prove this. This is something we can prove.
Absolutely, I totally agree. And Sonia add that her comment refers to the fact that early care provision can present chronification conditions, getting more severe, or even getting an emergency situation. And this is actually what we have seen also in our experience as emergency in Italy. In our clinic, where we do mainly primary health care, we have struggled with the system to have our clinics embedded in the national health system, in order to avoid that the only access for migrants to access healthcare is the emergency room. So by doing a preliminary screening in terms of primary health care, we have limited very much the number of accesses to healthcare, to the emergency rooms at the hospital. So this is something that we have data about, but still it's very difficult to be heard by the local, at least at the national and regional level health authorities. There is Caroline.
Yes, thanks. Just one more comment to echo what Paul said about prevention and tackling socioeconomic determinants of health. We all know that it's important. Still, across OECD countries, prevention is very low. So it's about 3% of health spending today. So for sure, we need to increase it and to make better prevention for improving the health for all. Thanks.
Sorry, we have 9 minutes left actually, but there are 2 more questions. So I will go to the first one, Deborah Glass. And she's asking what occupational health services do migrant workers receive? I don't know if any of you has any information about occupational health services.
Well,
Alessandro, maybe?
Well, we have, as emergency experience of the occupational health, they do not receive. So basically, we've collected data from our primary healthcare clinic in South Italy, in Calabria, where emergency has a primary healthcare clinic serving a population of seasonal workers, of agricultural laborers that are paid €2 per day. And we've gathered through our health information system the burden of disease, and it's basically very few studies in the literature in Europe for seasonal migrants, and it says that basically 60% of the reasons why they come to us is due to occupational medicine or medical or occupational health. They do not receive back pain, all these problems related to their poor working conditions. So, and this is another aspect that need to be highlighted by our work.
I think also Mariam raised her hand before. Maybe she wanted to intervene.
Yes.
Thank you. Regarding occupational working issues, I would like to underline that their conditions are really, as mentioned by Alessandro, very, very poor, and they were much more at risk for example, infection disease by COVID-19 virus. And we have some areas in Germany in the past seen where the infection was really very huge in these very, very vulnerable people, because they have to live in very small rooms together with I don't know how many people and in very precarious conditions. So this is very important to know and to look to these conditions and to share them also and to change the conditions. It's very important. Otherwise, it's difficult to deal with these conditions for these people. And the other topic which I wanted to mention is, for example, in Germany regarding the costs for these people in refugees and asylum-seeking vulnerable groups. In Germany, for example, we have the law of benefits for asylum seekers, which is a really huge barrier to access healthcare. It's not only mental health, but or healthcare services. And some colleagues did an experimental study, quasi-experimental study, in which they analyzed the data from insurance companies and compared them with the cost with also refugees and asylum-seeking people using services, and they find that this barrier is much more expensive. Germany has to pay a lot of money for this asylum or for this law of benefits for asylum seekers, and if they delayed it, it would be much cheaper for the system and much easier for refugees and asylum seeker people to access healthcare. So this is also a very important issue to think about it again. Thank you.
Very true. The last question from Bertina Crespai, I hope I pronounced it correctly, a PhD student at Karolinska Institute, to Paul, but open to all panelists. Building upon integration in the labor market, besides high-skilled migrants and the informal sector, many of those that are most vulnerable today are those that end up in unstable and atypical employment, who often automatically are not granted social benefits and social security, etc. Since these liberal labor market policies are increasing more than ever, and they do create labor market marginalization and adverse health outcomes, what could be an approach to tackle such policies or to try to mitigate their effects? So Paul, and then all the others.
Yeah, that's interesting and complex question. The first thing, maybe it's not just about the question of having a liberal labor market. I mean, the first thing is that, and again, there's evidence on that, a significant part of the jobs that are taken by the immigrants are jobs that the locals, I mean, the natives or whatever you want to call them, they just simply don't want to go to. So that's the first thing. So it's not just about liberalism. The second thing is that the legal framework is such, I mean, I'm not sure that it's the case in every country, but in many countries, that if you're illegal, basically you can't access the labor market for real, and therefore you cannot access the welfare system that is linked to the labor market. So if I can just give, I mean, it's more of an intuition or a belief, and you may not like it, but when it comes to the so-called gray economy, I don't think we could just think about, you know, putting this aside and saying this should not exist. I mean, immigration is not something simple. It's not an easy journey. It's not a fast track to integration. It's not that. So the real problem is when poverty becomes a trap. When you're trapped, you arrive in a country and you're trapped, say, in a very a job that is not satisfying. That's not good. But it has to be a pathway. I think it's more of an intuition, but it would be realistic to think that you could just avoid all these problems and all these shortcuts, or all these different ways, this heterogeneity of in the integration process. But we have to provide an integration pathway at some point. I mean, saying that, okay, you're here now, it's fine. And one day you can become a legal resident, and you can go through this and this and this, and we work not hand in hand, or at least we work together. And at some point somebody makes a decision. But the real problem is not really, I mean, it's not the gray economy, it's more about the poverty trap and how to avoid it. I'm not sure I completely answer your question, but it's a very long, it would be a very long answer otherwise.
And unfortunately, we have no more time. So, but I think that your conclusion that there is no magic stick to, but it's really a more of a long-term path, and we need a political will to go along this inclusion path that has to be really diverse and include all the different expertise. So I would like to thank all the speakers for their inputs. Thank Luciano and the Immigrants Alliance for involving us in this meeting, and I will leave the floor to Luciano to conclude it. Thank you so much to everybody for participating.
Thank you very much, Rossella, for chairing so well this panel. Thank you very much for the speakers, really excellent presentation, excellent discussion. Also, many thanks to the participants for being so active in the chat, many good questions. Again, thank you to Emergency for partnering with the Immigrants Alliance, for this important event. We learned a lot today. Again, there's so many other things to say, but I invite you to follow the next webinars of the series. We are having a monthly series of the Immigrants Alliance. I put in the chat the title of the next one, I think also very relevant, on sexual health for migrants. And I really hope that some of you will be there also to attend this meeting. Today, again, we heard very important points. I mean, I would say the bottom message is that indeed to take care of the migrants is something that from the ethical point of view, first of all, is very important, is essential, is an imperative, I think, for us Europeans, first of all, because European Union was created also on the basis of the tragedy of the Second World War, on the tragedy of migrants, migrating from some country to other countries in very difficult conditions. And today that, our situation, despite the problems that still we have, is much better than before. So we should be more generous also with people coming and trying to come to our land, because as Donata said, Australia is a fortress, but also Europe nowadays is a fortress. The number of people reaching us is very little, and the people who manage to reach us, they have to suffer through very long journeys, more than 2 years sometimes, and suffer so much. So I think, again, is an imperative for us to really keep in mind also what Mariam said, that health is a human right, and we have a charter that we have to remember, I think, every day. So thank you very much again to all of you, and see you soon on the, the screen of the Immigrants Alliance. Thanks.
Thank you.
Thank you.
Thank you.